Dr. Giuseppe Petralia, and he's going to speak about whole body MRI for cancer screening.
Good evening. It's a pleasure for me to be here in this beautiful session. And I hope it will start. Okay, good. So, whole body MRI is established for cancer screening in the high-risk population because it is recommended in the guidelines for the Fraumeni Syndrome, for the hereditary paraganglioma and pheochromocytoma syndrome, and so on. Let's take a closer look to the Fraumeni Syndrome. It is a germline mutation of the TP53, which is the so-called guardian of the genome. In simple words, when people have this syndrome, they develop cancer at higher percentages. It has been estimated that by the age of 30, women have cancer up to 50%, and the lifetime risk of having cancer is up to 100% for women and 70% for male. If we do whole body MRI in these patients, we see cancer with good percentages up to 30%. But what is interesting is that we can also have an impact on their survival, because if you look at this image on your right, you'll see that the red line is for a patient with Fraumeni Syndrome who did annual screening with whole body MRI. After 5,000 days, 13 years, almost 100% were alive, while the blue line is the survival for those with Fraumeni Syndrome who did not do annual screening. Well, they, after 13 years, they're alive only 60%. So there is a huge contribution in improving overall survival. And this explains why annual screening with whole body MRI is now recommended by guidelines in Australia, NCCN guidelines, and Canadian guidelines. First reason, because whole body MRI has a beautiful label on it: no radiation, no injection, no contrast. And second reason is because whole body MRI has good diagnostic performances. In this meta-analysis here, what I highlighted here, in this meta-analysis, what you can see is that has a comparable diagnostic performance with PET-CT in cancer patients for the diagnosis of primary cancer and metastasis. So if we look the sensitivities for both technique, 90%, the negative predictive value of whole body MRI in cancer patients is extremely high, 96%, and the specificity is good, 95%. Now we talk about the use of whole body MRI for cancer screening in the general population. Because it is increasingly used, many people like to have within their health check, annual health check, because it has no radiation, no contrast. And if you look well in the literature, you will find more papers that you can imagine describing the use of whole body MRI for cancer screening in the general population. And what are the targets for this exam? Here it is the list of the 10 most common cancers in the US. Of course, for the first 3, we already have good screenings. For prostate, we have PSA, for breast, we have mammography, for lung, we have low-dose CT, we have colonoscopy for colorectal cancer. But the other cancers on the top 10 list, they're not routinely screened. By that I mean urinary bladder, kidney, non-Hodgkin lymphoma, liver, pancreas. Those could be the good target for whole body MRI in the general population. And if we do whole body MRI in the general population, we can find cancer in about 2% of them, as it is shown in the literature. But on the other hand, we have to deal with a huge number of incidental findings, up to 99% in the literature. So we are in a challenge. On one hand, we want to maximize the potential and find the cancer. On the other hand, we want to minimize the harm and reduce the stress, the anxiety deriving potentially from the huge number of incidental findings. To minimize the harm, the key word here is negative predictive value. We saw from the meta-analysis before that if we use whole body MRI in cancer patients, we saw that our negative predictive value is high, is 95%. So if we apply the same test, whole body MRI, in the screening population where the prevalence of cancer is by definition lower, Therefore, the negative predictive value can only increase and by definition will be more than 95%. In real life, it means that if we see a negative whole body MRI, we can trust it and then give reassurance to our patient. As we said, on the other hand, we want to maximize our potential. The key word here is interpretation, because we need to have oncological expertise at multi-organ level. So we can call this bright lesion on the bladder a cancer, that was a bladder cancer, and then we can call a bright lesion on the liver just a liver hemangioma, requiring no further follow-up. And when we find something, then we need to classify our findings. If we look in the literature, there is a huge variability again. Some people classify findings in 2 groups, 3 groups, 4 groups, 5 groups. In our approach, we first divide body in 5 body regions, such as bone, brain, neck, chest, abdomen, pelvis, and limbs. And then for each finding in each body region, we give a score from 1 to 5 like a Likert scale. Being 1, what is normal, 2, something which is benign, like this, as you can see here, this lipoma, requiring no follow-up. Or 3, a lung nodule, which is probably benign, as we all know, but it is more than 6 millimeters. It requires 6 months follow-up with low-dose CT. Or this 5, the cancer before, we called it as 5, so very suspicious for cancer. We asked for cystoscopy, and a bladder cancer was found. And here I'm happy to share with you our preliminary observation at the Advanced Screening Center in Italy, a center that we opened 2 years ago. I sit in the scientific board along with Professor Padani here in this center. And here I share with you our preliminary observation on 1,300 subjects. We had a huge number of incidental findings as expected, 96%, exactly comparable with literature. The good news is that we called back only 24% of them for follow-up or further investigation, and we saw that when we reported Likert 3, we only had 1% of malignant cancer. When we reported Likert 4, we had 27% of malignant cancer, 5, we had 81%. This shows that in our population, with our system, this system worked quite well in stratifying the risk of having malignant cancer among our subjects. Overall, we found cancer in 23 subjects, which is about 2%, again, as expected from literature. And what is interesting is that even when we asked for a further investigation, in nearly 70% of cases, the investigation itself was non-invasive, with no contrast, no radiation, and it was motivated, because when we ask for a further investigation, in 10% of cases, there is cancer. And I'm sure you're asking to yourself, what cancer did you find? Here's the list. So, prostate, urinary bladder, colon, kidney, rectum. So, number is very small, so we cannot draw meaningful conclusion, but this is what we found. There are a few things that we learned. First thing about Likert 3. We saw, as we said before, that when we report Likert 3, there was malignant cancer in just 1%. And we observed that it behaves exactly like the category 3 of BI-RADS, where the prevalence of cancer is described more than 0%, but less than 2%. And then we learned about the distribution of Likert 3. The first sources of Likert 3 were chest because of lung nodules, neck because of thyroid nodules, we asked for ultrasound, then pelvis because of ovarian masses, and abdomen for pancreatic cystic lesion. But we learned something also about compliance, because we observed that when we reported the Likert 3, the compliance of our subjects was quite low. Only 60% followed our instruction regarding follow-up or further investigation, while the compliance was higher in Likert 4. The vast majority followed our instruction. Likert 5, they all followed our instruction. And then when you have findings, you classify them, then you have to manage the findings. And again, if you look back in the literature, there is a huge variability. Some people, some authors did a decision on a multidisciplinary board. One author said that he was sitting behind the scanner doing on time for the investigation, which is not practical. Others, they do. They ask for further investigation according to the body region. For example, if they see a lung nodule, they ask for CT. If they see a nodule in the thyroid, they ask for ultrasound, and so on, which is acceptable and mirrors more or less what we do. However, to do this well, you need a detailed knowledge of the guidelines and the best practices at multi-organ level. So you need to know how to deal with the lung nodules, to pancreatic cystic lesion, to focal liver lesion, to renal cyst, and so on. In our approach, we try to be as much as possible clinical radiologists, because we talk to our subject before the whole body MRI examination, and we explain clearly that whole body MRI is an advanced screening test, which comes in addition and never in substitution of the standard screening tests such as mammography, colonoscopy, pap test. And then we speak with our subjects after the examination to explain the result in order to lower the anxiety, because anxiety could be a problem. There is a paper showing that people who undergo whole body MRI for cancer screening, they can have strong distress while awaiting results in 10%, and 30% of them can have severe distress if they read the result after some days at home when they are alone without a doctor explaining to them. However, the same author said that on the long term, there were not big differences in people who did whole body MRI for screening and with people who did not whole body MRI for screening in terms of quality of life and depressive symptoms. We are now in our institution trying to address specifically the problem of the acceptability of whole body MRI for cancer screening. We did a pilot study on the short-term outcome, and we asked to our subject which were their expectations in terms of noise, confinement, shortness of breath, and exam duration before the exam. And their expectations were not that bad. More or less 70% of them did not have bad expectations. And then we asked what was the experience after the exam, after they received the report and were reassured by the doctor. In all cases, they said that the experience was significantly better than the expectation, which means, in simple words, that the exam was a positive experience. And now we are currently trying to address another problem on the long-term outcome. We are trying to evaluate the long-term effect at 6 months and 12 months in terms of quality of life, depressive symptom, and anxiety. Here it is. Our protocol, we perform a whole body MRI for cancer screening, both 1.5 and 3T. The exam duration it is 35 to 40 minutes. We have sagittal T2 steer on the spine, diffusion from the skull to the mid-thigh, axial T1, axial T2, T2 flare on the brain, plus a thin section gradient echo T1 for lung nodules. There are, of course, limitations. We may not see breast cancer. That's why we always say that whole body MRI has to be performed in addition to mammography. We may not see colorectal polyps, small cancers. That's why we say that whole body MRI has to be performed in addition to colonoscopy. And here my take-home message is. First take-home message is that we need to adapt our report to the risk group. Because one thing is to make a report on whole body MRI for cancer screening in the high-risk population, for example, Fraumeni Syndrome. They will develop cancer eventually. The lifetime risk of having cancer is 100%, so we should not be afraid to ask for further investigation. On the other hand, when we report whole body MRI for cancer screening in the general population, we have to keep well in mind that the prevalence of cancer is low, 2%, and our negative predictive value is extremely high, more than 95%. Therefore, we should not over-investigate to lower the level of anxiety. And then last but not least, I personally think that whole body MRI for cancer screening is a unique opportunity that we have to become doctor again, to talk to our patient before the exam, after the exam to explain the result, and to take on the onward management with a dream in our mind to give a good contribution to the early diagnosis of cancer with whole body MRI, which we all know saves lives and eventually cuts treatment costs. Thank you.
Thank you for this very interesting talk.